All right, let's jump right into some of the most high-stakes topics in peds nursing. Think of this as your lightning-fast review for those neuro, onco, and heme emergencies you've absolutely got to know. Not just for your exams, but for real-world practice. We're going to start with a classic neurologic red flag.
Okay, picture this. You walk into a room and you hear it. It's an infant's cry, but it's not a normal cry. It's sharp, it's high-pitched. This is not just a fussy baby, you guys. This is a massive neurologic red flag, and it's screaming that there's a huge problem building up inside that tiny skull.
In that huge problem, it's increased intracranial pressure, or what we all call ICP. Seriously, this is one of the most critical things you'll ever learn in pediatric neuro. Because spotting this early, it can literally be the difference between a good outcome and a truly devastating one.
So what exactly is ICP? Well, just think about the skull as a closed box. It's got three things inside: brain, blood, and CSF. There's no extra room. So if one of those things starts to swell or increase, something else has to give, or the pressure just skyrockets. That's ICP. The real key here, the thing you have to remember, is to catch it early. You're looking for things like that irritability, the high-pitched cry, maybe some vomiting, and in an infant, you can actually feel a tense, bulging fontanelle. If you miss those early signs, you're heading into a real crisis with the late signs. And Cushing's triad, that's when you see high blood pressure, a super low heart rate, and crazy irregular breathing. That is a terrible, terrible sign that the brain is about to herniate.
Okay, now you have to burn this image into your brain. Sunset eyes. See how you can see the white of the eye, the sclera, above the iris? It looks just like a setting sun. This is happening because there's so much pressure on the cranial nerves that control eye movement. This is not a subtle sign. This is a drop everything and report it immediately kind of sign.
Now, when that pressure gets really, really bad, the body starts to posture. There are two types you've got to know. First is decorticate. See how the arms are flexed inward? The easy way to remember this is that the arms are coming in to the core. This tells you there's damage to the cerebral cortex. Then you have decerebrate. This is rigid extension of both the arms and the legs, and this points to damage way down deep near the brainstem. So let me be crystal clear about this. Decerebrate is always worse. Always. Why? Because it means the damage is to the brainstem. And what does the brainstem control? Oh, just the little things, like breathing, heart rate, staying conscious. It's a sign of a really, really profound brain injury. Okay, so we know how to spot the danger signs, but what do we actually do? What are our first moves when we're in a crisis? Let's break down what to do for seizures, meningitis, and a failing VP shunt.
When a child is having a seizure, your brain needs to scream one word: safety. That's it. Safety first, always. Your first move? Turn them on their side. That protects their airway. Then, clear the area. Get any hard or sharp objects away from them. Start timing it. When did it start? When did it stop? And I cannot say this enough. Never, ever put anything in their mouth. You're not helping. You could break their teeth or make them choke. Just keep them safe and their airway clear. Okay, bacterial meningitis. This is a flat-out race against the clock. The classic signs you're looking for are fever, a serious sensitivity to light, that's photophobia, and a stiff neck. Your very first move, before you do anything else, is to get them on droplet precautions. Put on a mask. You have to protect yourself and everyone else. But the most critical intervention? Getting IV antibiotics started ASAP. I mean right away. Don't even wait for the lumbar puncture results to come back. Every single minute you wait is a minute lost. All right, let's talk about hydrocephalus and VP shunts. So a lot of these kids have a shunt to drain that extra fluid from their brain. But what happens when it stops working? Well, it's pretty simple, actually. All those signs of increased ICP we just talked about, they come roaring back. The vomiting, the irritability, the bulging fontanelle. And what if it's infected? You're going to see a fever and probably some redness right along the path of the shunt tubing. And here's a huge post-op tip. You have to keep the child lying flat at first. If they sit up too fast, the fluid can drain way too quickly. And that causes a whole different set of major problems. Okay, let's switch gears a bit and move into pediatric oncology. Now, if there's ever a time when the nurse's role as a protector is front and center, this is it. We're talking about some of the most vulnerable kids you'll ever care for, where one tiny mistake can have absolutely massive consequences. And that brings us to what might be one of the single biggest, most absolute safety rules in all of pediatrics. If you even suspect a child has a Wilms tumor,
which usually shows up as a mass in their belly, you do not, under any circumstances, palpate their abdomen. Don't push on their belly, period. So why are we so intense about this? Here's the deal. A Wilms tumor is a kidney cancer that's neatly wrapped up in a little capsule. It's contained. But if you push on it, even just a little, you can break that capsule open. And if that happens, you've just seeded cancer cells all over their abdomen. You've just turned a localized problem into a massive metastatic crisis. That's why we don't touch it.
Now with leukemia, the child's bone marrow is basically failing. That means you're fighting a war on two fronts, infection risk and bleeding risk. For infection, their immune system is shot, so you've got to put them on neutropenic precautions. That means a private room and no fresh flowers or fruit that can carry germs. For bleeding, their platelets are low, so everything has to be gentle. Soft toothbrush, absolutely no rectal temps, and keep your eyes peeled for petechiae, those tiny little pinpoint bruises. And this is critical. No live vaccines while they're getting chemo. Their bodies just can't handle it.
All right, so we've talked about these big, acute crises. But what about the long haul? Let's shift our focus to managing chronic conditions and how we support kids with lifelong hematology and musculoskeletal issues.
When a child comes in with a sickle cell crisis, I want you to think of one word, HOP. H-O-P. This is your action plan. H is for hydration. You got to flood them with IV fluids to help flush those sticky, sickled cells through their vessels. O is for oxygen. This helps prevent even more cells from sickling up. And P is for pain. And listen, the pain from this is no joke. It's a 10 out of 10 pain. These kids need and deserve aggressive pain control with opioids. Here's a pro tip for treating iron deficiency anemia. How you give the iron matters. A lot. You want to give it with something high in vitamin C, like orange juice. That vitamin C is like a supercharger for iron absorption. On the flip side, you want to completely avoid giving it with milk or anything with calcium because that just blocks it. It's such a simple little trick, but it makes a huge difference in how much iron their body actually uses.
Okay, you have a newborn with spina bifida, your priorities are immediate, and there are 3 things you have to do right now. 1, protect the sac. You need to cover that exposed area with a sterile, moist, non-adherent dressing, keep it from drying out and getting infected. 2, positioning. The baby has to be prone, lying on their belly, to keep any and all pressure off that sac. And 3, think allergies. This population has a super high risk for latex allergies, so you need to start latex precautions from day 1. All right, let's do a quick fire round of some classic signs you'll see on your exams. See a kid walking their hands up their legs just to stand up? That's Gower's sign, and you should be thinking Duchenne muscular dystrophy. See a child with blue-tinged sclera and a history of frequent fractures? That screams osteogenesis imperfecta, or brittle bone disease. And if you see an infant in a Public harness, that's being used to correct developmental dysplasia of the hip. All right, we are in the home stretch now. Let's wrap this all up with a super high-yield review. We're going to touch on one really important diet, and then hammer home the absolute must-know points for your exam. First off, the ketogenic diet. This is not a trendy weight loss thing. For kids with epilepsy, this is a serious medical therapy used to control seizures when meds don't work. I mean, look at this breakdown. It is almost entirely fat. The whole point is to force the body into a state of ketosis because ketones can actually help calm the brain and reduce seizures. The most important thing for you and the family to understand is that it has to be followed perfectly. 1 cookie, 1 piece of bread, any small amount of carbs can kick them out of ketosis and the seizures can come right back. Okay, here it is, your final cheat sheet. When you're totally stuck on a question, just think safety, airway, prevention. That's your hierarchy. Remember your key positions: prone for spina bifida, sideline for seizures. And please, please burn these 2 absolute rules into your brain forever. Rule 1, no aspirin for a kid with a virus. It can cause Ray's syndrome, which is this horrifying condition that causes swelling in the liver and the brain. Rule 2, no palpating the belly of a kid with a suspected Wilms tumor. We already covered why that's so dangerous.
So I want to leave you with this one final thought. The next time you're in a pediatric crisis, and you will be, when the alarms are ringing and everyone's rushing around, I want you to ask yourself one single question. What's the one question that will cut through all that chaos and ground you? Just ask, what is the absolute safest thing I can do for this child right here, right now? Let that be your guide.